अक्टूबर का महीना है, ब्रेस्ट कैंसर अवेयरनेस का मंथ है, तो इसलिए हमने सोचा कि आपके साथ ब्रेस्ट अवेयरनेस पे एक सेशन हमें करना चाहिए, क्योंकि अभी ब्रेस्ट कैंसर बहुत तेजी से बढ़ रहा है. As per the data, as per the statistics, हर 4 मिनट में एक महिला इंडिया में डायग्नोज होती है with breast cancer. I mean, every 4 minutes, one woman is diagnosed with breast cancer. Every 13 minutes, we lose a woman to breast cancer. काफी भारी नंबर्स लगते हैं, है ना, जब हम इन नंबर्स को सुनते हैं. लेकिन इसमें अच्छी स्टोरी ये है कि more than 85% of the breast cancer, they are preventable, they are avoidable. हम उनको बिल्कुल अपनी जिंदगी से बाहर रख सकते हैं. ये सबसे अच्छी स्टोरी है, और इस स्टोरी के ऊपर संजीवनी लाइफ बियॉन्ड कैंसर काम करती है.
I would like to welcome Dr. Pompi D.Burhagohain. She is designated as an assistant professor in Dr. B. Borah Cancer Institute Breast Service. She completed her MBBS from GMCH in the year 2008, MS in 2013, Senior Breast Oncosurgery Fellowship from TMH, worked in TMH from 2021 to 2023. She has also done many international and national researches and has written many publications.
Today we will discuss about genetics and the clinical implications on it. To move on to the next slide. As we all know, breast cancer is a major public health problem for women, not only in India but throughout the world. It is the most frequent cancer in women and the second most frequent cause of cancer, that's in women. Breast cancer is a heterogeneous disease which is caused by progressive accumulation of genetic aberrations. Next slide, please. To begin with, majority of breast cancers, they appear to occur sporadically. That is, genetic नहीं है, वो ऐसे ही हो सकता है किसी को भी. So germline mutation, it accounts for approximately only 10% of all breast cancers and are associated with several breast cancer syndromes. Family history represents one of the most important risk factors for breast cancer, and it comprises of almost 20% of all breast cancers. Next slide, please. So there are a few susceptible genes, breast cancer genes, but however, I will mention only the ones which have a very high risk penetration. These are the BRCA1 and BRCA2 mutation, TP53 mutation, P10 mutation, CDH1 mutation, and STK11 mutation. Next slide, please. Okay, so how are you going to doubt, or what are the red flags for you having a hereditary breast cancer? First of all, I would again like to emphasize on the fact that of all the breast cancer cases, only 5 to 10% are hereditary. So breast cancer with an onset of less than 40 years, patients having bilateral breast cancer, that is a breast cancer including both the left as well as the right side, ovarian cancer at any age group, male breast cancers, multiple family members with an early onset of breast cancer, and multiple affected generations. These are, you might suspect that you might be having a history of hereditary breast cancer. Next slide, please. So family history. How important is family history? It should be kept in mind that 15% of breast cancer patients have a positive family history. There is no family history in the remaining 85%. Patients with a first-degree relative with breast cancer have twice or 3-4 risk of breast cancer. Risk is much higher if the affected first-degree relative had premenopausal onset and bilateral breast cancer. The risk decreases in women with a distant relative affected with breast cancer. The positive family history may be familial or hereditary. It is not necessary that if there is a history of breast cancer in the family, it doesn't invariably needs to be hereditary. It can be familial as well. Next slide. So there are a few risk factors that I've given here where we would suggest you to go for a genetic evaluation. So if a patient has been diagnosed with breast cancer, DCIs or invasive breast cancer, and if they include any one of the following categories, if they have been diagnosed at the age of below the age of 50 years old, if they have triple negative breast cancers diagnosed at any age, and if they have a known mutation in a cancer susceptible gene within the family, and if they have an additional breast cancer primary, if one or more close blood relatives, that is first or second degree, with a breast cancer diagnosed at an age of 50 years or younger, one or more close blood relatives with ovarian cancer diagnosed at any age, if there are two or more close blood relatives with breast cancer, pancreatic cancer, or prostate cancer at any given age. This obviously does not apply to us, but generally the individuals of the Ashkenazi Jewish ancestry, they have a very high chances of having a BRCA positive mutation in them. Male breast cancers. Secondly, any personal history of any kinds of cancer in the body, be it an ovarian cancer, is also gives you a chance or a risk of you having a hereditary or a mutation for which you can undergo a genetic evaluation. Now, patients who have not been diagnosed cancer can also undergo further genetic risk evaluation if they have a close relative who has a known mutation in a cancer susceptible gene, two or more breast primaries in a single individual, two or more individuals with breast cancer on the same side of the family with at least one diagnosed at the age of 50 years or younger, ovarian cancer and male breast cancer, first or second degree relative with cancer at the age of 45 years or younger, and a family history of three or more of the following cancers. This includes the breast cancer, pancreatic cancer, prostate cancer, melanoma, sarcomas, adrenal cortical sarcomas, brain tumors, leukemia, diffuse gastric cancer, colon cancer, endometrial cancer, thyroid cancer, kidney cancer, dermatological manifestations, and or macrocephaly or hematomatous polyps of the GI tract. Next slide, please. So coming to BRCA1 and BRCA2. So BRCA1 and BRCA2, they mainly constitute almost 80% of the hereditary breast cancer. Women with these kinds of gene changes, they have up to a 85% chance of getting breast cancer during the lifetime. There is a significant portion of hereditary breast cancer that is unexplained. Having said that, the incidence of BRCA1 and BRCA2 mutation is only 0.2% in general. Next slide, please. So BRCA1 predisposes to both breast cancer as well as prostate cancer. There is a 50% chance of developing bilateral breast cancer in women who have a BRCA1 mutation. Women with BRCA2 mutations are predisposed to ovarian cancer, pancreatic cancer, prostate cancer, and breast cancer. They are especially associated with the male breast cancer and bilateral breast cancer. Next slide, please. The other mutations that I have already mentioned, they confer to around an 8 to 10-fold increase in the risk of breast cancer as compared to non-carriers, and collectively they account for less than 1% of all breast cancers. Next slide. So management strategies for high-risk women. So if you fall into any of the categories that I have mentioned earlier, so how are we going to manage you? One way is that we will start with an intensive surveillance, chemo prevention, prophylactic surgery in the form of bilateral mastectomy or bilateral salpingo-oophorectomy. Bilateral mastectomy, it gives you a 90 to 94% protection against breast cancer. Bilateral salpingo-oophorectomy, they give you an added prevention from ovarian cancer as well. Secondly, coming to chemo prevention, we do advise tamoxifen in patients who are carriers of BRCA1 or BRCA2 mutation for a period of 5 years. And coming to intensive surveillance, high risk of breast cancer development, even if it is due to genetic factors or due to history of prior thoracic irradiation or a lifetime risk of 20% or greater, screening with MRI is recommended. Next slide, please. So how are we going to do the surveillance in a high-risk patients? Breast cancer awareness should start at the age of 18 years. Clinical breast examination every 6 to 12 months starting at the age of 25 years. Breast screening in the form of mammography. For women who are of age 25 to 29, we would suggest an annual MRI. and for women who are 30 to 75 years age, an annual mammography. Now, those patients who has been treated for breast cancer and who are carriers of BRCA mutations, we do advise them a screening with an annual mammogram as well as an annual MRI. So what we do is that we alternate mammography with an MRI. So if you have come to a doctor with an annual mammography which is done, then for the next 6 months later, we will ask you to get an MRI, which will be followed consecutively again by the next 6 months later. We will do another mammo and vice versa. So basically, this is how we would proceed with a patient who falls into the risk of having an hereditary breast cancer or who are high-risk patients with a family history. If you have a very significant family history, we do counsel them for a genetic counseling, and accordingly, we do proceed ahead with a testing for the genetic mutations. Thank you, and I'm very honored to be a part of the Sanjeevani team today. Thank you so much.
I really want to extend my thanks to NMDC, which is doing a great job in nation building as far as their core strength is concerned. But उसके अलावा बहुत ही socially aware organization है, and इस तरह के webinars जो हम करते हैं उनको हमेशा support करती है, and because of that support we are able to reach thousands of people. तो आप लोग जो हमारे साथ Zoom पे directly अभी connected हो, इसके अलावा this webinar will be live on Facebook and other social media platforms, and I'm sure a lot of people will benefit because of this webinar. So thank you, NMDC. Also a very big thanks to Phenobank, who has come forward to support this webinar.